And so if you have any questions, please use the chat function that's there, and I'll address them probably at the end of the talk. Um, if any of you are happy to have your video on, it'd be much appreciated. So I don't have to talk to a black screen, but I understand people never want to have their video on. And so we'll just get started. I think looks like we've had most people arrive, which are going to arrive. Thank you very much for the video, much appreciated. So let's start at the start. My name is Kellam Bayley. I'm a specialist veterinary ophthalmologist based in Hamilton, and I've been based in this clinic for probably the last couple of years. Prior to that was sort of based in Wellington full-time for the 10 years before that. I wanted to kind of create this webinar and deliver this really as a bit of a sort of a discussion about vision loss in dogs, the most common types that we see, and also sort of highlight cataracts and cataract surgery and what your options are for treatment for that. And so to get through what we plan to cover, if my slideshow will move forwards, is we're going to talk about useful neurological assessment techniques for assessing cases with concern about vision, cover differential diagnoses for these vision loss cases, and really then spend time talking about the most common causes of vision loss in dogs, which would be cataracts, SARDS or sudden acquired retinal degeneration syndrome, and also PRA or progressive retinal atrophy. And we will discuss specifically a bit of information about diabetics and my take on diabetic cases with vision loss. As I say, if you have questions, there is a chat feature on Zoom, which I'd recommend you type your questions into, and I will address them at the end in sequence. When it comes to assessing cases with vision loss, you really want to sort of approach this in as sort of thorough and systematic way as possible. So it's really nice to start off with a history assessment. So looking at what's the nature of the vision loss. Is it something that's present during the day, or is it worse during night? Is there any other features for it? Has it been sudden onset? Has it been slowly progressive? Those sorts of features will help kind of inform what the most likely cause of that vision loss would be. Also, are there any other conditions which may be relevant? So most commonly, as we say, if it's a diabetic dog, potentially talking about diabetic cataracts, that would explain vision loss, or maybe there's cushingoid type symptoms which may be associated with SARDS, which we're going to cover a bit later in the talk. We won't go through a thorough ophthalmic assessment sort of approach today because it's, I'm trying to keep this as a condensed, digestible webinar rather than a epic sermon. But briefly, it's really important, I think, to assess these structures in a logical manner. I like to do them from superficial to deep, so starting at the most superficial structures and then making our way progressively deeper as we go. I wrote an article in the VetScript in, what was it, April 24, just on the topic of ophthalmic exam. And that kind of runs through a lot of this stuff in a little bit more detail than we're probably going to cover today. And also it does cover the neurology. And at the end of it, there is an ophthalmic exam sheet as an example that, I mean, it's pretty much exactly what I still use now. And I think it's really quite a powerful tool to have an exam sheet, kind of checklist type sort of situation where you're trying to do a series of assessments and recording the information as you go. I think having a checklist is helps free up your mind to do the actual testing and think about the results rather than trying to remember what tests you need to do next. So if you've already got that list of tests that you need to do written down, then it just kind of gives you a little bit more space in your mind to think about things. And I think it's useful for ophthalmic exam. I use them for neurological assessments as well, for cranial nerve assessments. But you can do them for it's not an eye specific strategy, but I think it's quite useful. And so then once we've done, we're going to do a thorough exam. We're also going to assess neurological function because that's going to be really important when we're trying to determine what the most likely cause of our vision loss is. And also, if we're able to have a look at the retina and optic nerve, then that gives us really good information as well about the most likely cause of that vision loss. In your in the notes that I set out, there's at the bottom there's an area which sort of says resources, for that support this talk, and one of them is we've got some videos and stuff on our website, including techniques of how to do fundus exams. So again, we won't cover that real in a lot of detail today, but it's something which, if you're motivated to try and expand your ability and diagnostic ability in ophthalmology, but also in cranial neurology, having a fundus exam ability is a real kind of feather in your cap, and it's quite useful. Oops. So when it comes to ocular reflexes, there's a sort of a core group, which I think are valuable in all cases. There's a few others as well, which can be useful, but I don't necessarily do in all patients. But really, I think the core group are the palpebral reflex, where, you see if they're able to blink to a tactile stimuli, pupillary light reflex, both direct and indirect, Daser reflex, menace response, and tracking response. And we'll cover a few of those, I think most of those in a bit more detail in the upcoming slides. There are others that you can use. So, like, for example, you could use a corneal touch reflex, so touching the surface of the eye with a little stimuli and seeing if they blink in response to that. Things like that I don't necessarily do in all cases unless I'm concerned about that. The tricky part with cranial neurology, or neurology in general, but particularly cranial neurology, I think, and ophthalmology, is understanding the pathway. So understanding what components are involved and how you can use that knowledge to identify where the lesion is most likely to be in that patient. And there's a lot of work to get your head around that and start to remember that. But I would really encourage you to start practicing these nerve reflex testing, and then that will help start kind of consolidate the neuroanatomy and your understanding of the pathways and things. And once you've got your ocular reflex profile, it's important to combine that with a physical exam and an ophthalmic exam and a fundus exam if possible. And the most obvious example of why a fundus exam would be valuable is that we've got images of two different dogs' funduses, optic nerves on the right there. And these dogs may have the exact same neurological profile. They may have the exact same reflex profile. Maybe they've got no PLR, no DASL, no menace response. And so based just on the neurology, they look the same. But as soon as you look at the retina and the optic nerve, you can see they look very, very different. And so the one up the top is very normal looking optic nerve head compared to the one down the bottom, which is really classic, appearing for progressive retinal atrophy. There's no blood vessels you can see there. The optic nerve is shrunken and pale, and there's the pedal hyperreflectivity. It's very, very bright reflection there. And so, the differential diagnosis for those two cases is dramatically affected with a fundus exam. I don't think you need to be able to do a fundus exam to do a really good quality neurological assessment, but it's a real useful tool, particularly for vision loss cases. And so we will run through a few of the core reflexes now in a bit more detail, and just sort of describe to you how I like to do them and the value of them. So the pupillary light reflex is a really common reflex we should all be familiar with. But essentially, light going into the eye causes pupil constriction to reduce the amount of light hitting the retina. There's two components to it. One is the direct pupillary light reflex. We're shining light in the eye and we're looking at the response of that eye to the light in that eye. And then there's the indirect pupillary light reflex, where we're shining light into one eye, but we're actually observing the response to the light in the other eye, which is not currently being stimulated. And the reason that we've got pupil responses in both eyes is because at the optic chiasm, where the optic nerves from both eyes kind of cross, some fibers go to the left, some fibers go to the right. And so we actually stimulate both sides of the brain, even if we are only stimulating one eye with light. And so that means that we have pupil constriction in both eyes. And when I first started being interested in this, the way I'd try and assess this was I'd shine light into one eye and then I'd try and peer around and look at the other eye. But that doesn't really work, because if you've got light going into one eye and you're looking at a dark pupil in a dark eye with no light on it to try and assess the indirect PLR, you just can't see anything. And so the way around that is to kind of do more of a dynamic testing and using light and the knowledge of the reflex pathways to test both the direct PLR and the indirect PLR at the same time. So this is where a so-called swinging light test is quite valuable. And so this is how we do it in this patient here. So basically we are pushing light into one eye, coming across the nose, and then putting light into the second eye. When we first put light into the first eye, we're getting a direct pupillary light reflex. When we then come across the nose, but just before we're putting a lot of light into the second eye, that second eye is under an indirect pupillary light reflex status. Then as the light goes into that second eye, it converts to a direct pupillary light reflex. So essentially when we're following the light, so looking straight down the light, and we're going from one eye to the other, to the other, to the other. And by doing that and assessing the pupil as it moves during that different light stimuli, we're able to get a really good idea of what the direct PLR and the indirect PLR is for both eyes at like the same time. And so in real time, what I do is I'll look down my my light source. I like to use a thin-off transilluminator as a stimuli. So, it's just a pretty standard battery pack, which I'm sure you all have with the different heads that you can put on. And this is just a single light source. It's been chewed, which is why there's a dent in it. But you can use your otoscope attachment as well. That's fine. It's a nice quality light. My battery's a bit flat, but it's a nice quality light, nice even light, and you can change the light intensity with the rheostat on the side. I really like this tool. And so when I'm doing the direct PLR, I'm just looking straight down the barrel of it and then just bouncing over the nose like that. And so we'll just go through this case again, and I will kind of sort of narrate what reflexes we're looking at the time with it. So putting light in the eye first, we're seeing a direct PLR, then we come across, and then when the light first hits the eye, it's an indirect PLR, and then soon afterwards, it converts to a direct PLR. And you'll see that particularly as we're coming across back again, that as it goes from an indirect to a direct PLR, we just get a little bit more of a squeeze. All right, so the pupil constriction for a direct PLR is a little bit more intense for an indirect PLR. So you would expect to see some movement of the pupil as you change between those reflexes. It's best done in a dark room. So this was, I recorded this, so it was a relatively brightly lit room. PLR testing is best done in a dark room if at all possible. And that's because if you're in a bright room and the pupil is this wide when you start, and then you put light into the eye and it constricts fully to this, that's way more difficult to see than if it was a dark room and the pupil started out here and then constricted down to here. All right, so if you're in a dark environment, the magnitude of change is much greater than if you're in a brightly lit environment. Desert reflex is I think a really useful reflex to use because it has some shared pathways with the pupillary light reflex, but the way it's expressed is different. So the pupillary light reflex, we shine light into the eye, the pupil gets smaller. But for a dazzle reflex, we shine bright light into the eye and the eyelids close. So it's a different motor pathway. It uses different nerves and different muscles to show a positive response. And it's really useful if the pupil's abnormal. So it's not uncommon to see these little old poodly type dogs with fairly dilated, non-responsive pupils. You could easily say that the PLR is abnormal in that case, and then potentially be concerned about vision loss. But you're able to test most of that PLR pathway, or the whole afferent pathway anyway, with the dazzle reflex. And if the dog blinks its eyes, then it does tell you that it does have the functional afferent pathway. Which is the same pathway as for the PLR. But you do need to use a light which is really offensively bright. You need to use a sort of light where you look and go, oh, God, that's awful, and you want to close your eyes. It's more of an avoidance reflex. And so a good quality, awful light to use is just your cell phone light. Turned up really high. It's really bright. So this dog here, we're doing a dazzle, but we had to turn the light up to full, and you'll see how bright this is. And you'll see her kind of twitching her eyes, and that's awful. That's so bright. But that's what we're looking at for a dazzle reflex. Obviously, it'll be a bit more obvious to you because your eyes won't be bleached out like my cell phone camera is here. The other side of that is that if you ever try to do a pupillary light reflex test or an eye exam with the light from your cell phone, you'll really struggle because the dog's going to want to sort of blink and squint and get away from it because it's so offensively bright. So it's a really nice to have that tool to, your cell phone or similar really awful bright light to do the dazzle reflex testing, but it's not a great exam light because it's just too bright for them to tolerate. Track and response. So track and response is where we drop a or move a target through the visual field and see if the patient is able to follow it. So if we drop something down in front of the patient and they're looking up at it and then they track their head down as it goes towards the ground, hits the ground, then that's a positive tracking reflex, or tracking response rather. Um, I quite like it to assess visual acuity. It's not going to be accurate to assess visual acuity. It's not like, oh, we'll drop this and the dog's got 20/40 vision, but it is probably more accurate, more useful anyway, than say a menace response or any of these light reflexes. Um, I also really like to use it to differentiate between visual performance in bright circumstances and dark circumstances. So you can turn the lights off in the consult, do the test initially with the lights on, turn the lights off in the consult room, and then repeat it and see whether the animal will track the moving target, even though the light is dimmer. How dim should the light be? Well, I reckon that the way I think about it is that for dogs, their eyes are set up to be more effective at having functional vision in darker lighting than us, right? They're designed to hunt in dim lighting, dawn and dusk, and also their eyes are better set up to detect vision than ours. And so my thoughts are that if the room is dark, so dark, is very dark, but I can still see the thing moving, then that dog should definitely be able to see it moving. Um, Obviously, you can't have the room so dark you can't see the dog because then you can't test it. So, but generally, you want the room, quite dark. Um, this is a talk about vision loss in dogs, so we're not really talking about cats and that sort of any other species at this stage. But I would say that all of these neurological tests have their value in other species, but how their function and how valuable they are is a bit different. So this is not going to be a useful test for trying to assess visual performance in cats because they're just not going to track a moving target like that. Unless you happen to have a very playful cat that's a bit relaxed, maybe you can get the laser pointer out or something like that. But I think cats are just a little bit too unreliable for neurotesting for this to be useful. And so here's our same little patient in a relatively dark room. You can see that we're throwing cotton wool balls towards her, and she's clearly picking it up as it's moving and tracking it down. But you want to make sure that they're actually looking at you when you do the testing because there's no point doing it now. She's not going to respond to that. So get her attention and then move that ball down. Sounds kind of obvious, but you want to make it a visual stimuli, all right? So you don't want to like hit her in the face with a cotton wool ball because she'll react to that. But it happens surprisingly often as you're dropping down cotton swabs or something like that it might brush a whisker if you're a bit close. Um, and you want to use a target which is not going to make any sound when it hits the ground, which is why we're using like a cotton wool ball or a cotton swab or something along those lines. Because if you threw a tennis ball, for example, through the air and it didn't see it, presuming it wasn't also deaf, as soon as it hit the ground, it would point straight to it because it would hear it hit the ground and go, "Oh, what was that?" So you can't use a target which makes sound. You probably also shouldn't use a target that smells, but I don't know that that's that big a deal. But cotton swabs and cotton balls are really the way to go. I'm not specifically going to talk about menace response testing here because that's the response reflex neurological pathway is actually quite complicated, but the actual testing of it is not super difficult. There's no kind of real pro tips to that. Cover one eye, do a menacing gesture, see if you get a response, cover the other eye, and repeat. Okay. One thing that we see in all patients, moving on from reflex testing, one thing that we see in all patients once they're beyond middle age is that the eyes become more cloudy and foggy in appearance, and that could easily be it may be a cataract, certainly can easily be confused with a cataract. But there's a condition called lenticular nuclear sclerosis, which occurs in all species beyond middle age. This is where the lens itself, as it ages, becomes more compressed and becomes denser. It also becomes less perfectly transparent. And you have this kind of grey, bluey looking pupil, rather than that kind of jet black pupil that you would expect to see in a younger animal. It's something which is not blinding. When really severe, it might impair vision a bit, but that's usually in your 15 or so year old poodle or similar dog. And importantly, it's not cataract. And so these sorts of lens opacities, we don't operate on these in veterinary patients because they're not significantly impairing to vision. And if we did surgery on the lens that when it wasn't really a lens problem, we probably wouldn't get a great deal of improvement. So being able to differentiate between lenticular nuclear sclerosis and cataract is really quite a valuable tool to have. And it's something I think can be done pretty easily. And it's just if you look at the eye under retroillumination. And the tech, you can do that just with a light source, but the technique I really like to use is distant direct ophthalmoscopy, where we're actually using the ophthalmoscope. I'm pretty sure we cover that in a future slide. So retroillumination itself is when we're actually putting light into the eye, but we're actually viewing it at an angle from the light that is reflected back towards us from the fundus. And so in most of our veterinary species with the tapetum, you might have this yellowy, greeny reflection coming back at you. That's what we're actually assessing under retroillumination. Distant direct ophthalmoscopy, which I've got a video to show that to you. We've got the how to set up the machine and set up yourself technique is on our website. I think it's probably also in the VetScript article I wrote a few years ago. But it's a really nice way to help differentiate between lens imperfections in lens clarity versus cataracts or obstructions to lens clarity. Because we are assessing the light as it's coming back towards us, anything which is opaque is going to be between us and the reflected light. So we're going to cast a shadow. And the reason that this is valuable is that under retroillumination, if you've got a cataract, what you're going to see is a dark area surrounded by a really brilliantly reflective light, maybe brilliantly green or yellow or orange or whatever color it happens to be. Whereas if you're trying to look at that same opacity with just a direct illumination, just looking straight down the torch, like we do for our pupillary light reflex testing, you're going to be using a white light to find a white cataract on a white background. Like you just don't have the same resolution. So it's a lot easier to get confused. And I'll admit, I've had the odd case of lenticular nuclear sclerosis where initially if I've looked just with direct illumination, I think, oh, that looks like a cataract. But then when you actually really critically evaluate the optical axis clarity with the retroillumination, it does sort of highlight how clear or otherwise it is. And so what we're doing, we're using the direct ophthalmoscope and we're maintaining a distance of about arm's length away, and looking at the reflection from that distance. So this is a normal dog. So you can see there's a really brilliant reflection coming back through the ophthalmoscope through the pupils. It's also quite a useful way to look at pupil diameter because you get that reflection and you can see both pupil diameters at the same time. So it's quite useful for that. These other videos, there are a couple cases which are in for cataract surgery, and by looking at this case under retroillumination, we get to be able to estimate quite accurately the severity and extent of the cataract in this patient. So we've got quite a mature cataract in the right eye and a complete but immature cataract in the left eye. This dog's a little bit similar in that we've got a nearly totally mature cataract in the left eye here, just a tiny little bit of tapetal reflection through it. But then we compare that to the other eye where the reflection is almost normal, except we've got a cataract right in the back of the lens there, just a sort of a fairly small area. I might just play this white dog again. So it's something which we can use to critically evaluate optical clarity, but also give us a bit of an estimate of the degree of opacification in that visual axis. And that's going to again sort of feed into our differential list and what we're thinking may be the most likely cause of the vision loss in our patient that we've got in front of us. So the main differential diagnoses for bilateral vision loss in dogs, well, we've got cataracts, and there's a few different types of cataracts. We've got, I'm sorry, I'm just going to skip ahead a little bit. Okay. A few different types of cataracts. So we've got the diabetic cataract, which is really important of sudden vision loss in dogs, obviously in diabetic dogs, but in dogs. Um, Genetic cataracts, usually they'll have an age of onset, usually as a young to middle-aged adult, sometimes older. And then you've got senile cataracts in our very old patients, 12 plus years. They're all a little bit different. How we go about them may be a little bit different. Uh, and so if you've got lens disease, that can cause vision loss. If you've got retinal disease, that can also cause vision loss. So you've got progressive retinal atrophy, which is actually a chronic progressive condition. It sometimes can present acutely. Um, Sudden acquired retinal degeneration syndrome, or SARDS, is a really important cause of vision loss in dogs, and they typically will present pretty suddenly. Retinal detachment is pretty uncommon, but it does happen. And obviously, if you've got a detached retina, you're going to have impaired vision or no vision in the affected eye or eyes. And then other areas where you can get vision loss originating would be in the optic nerve. So if you've got damage to the optic nerve, which is effectively the communication cable between the eye and the brain, well, obviously the brain's not going to get input from the eye, so we won't have functional vision. And then if you have central nervous disease as well, somewhere in the visual pathway in the brain, that can cause vision loss as well. So what we're going to do today is kind of talk about the lens and a couple of retinal disorders, just because they're the most commonly encountered ones. Not to say that the others don't occur; they certainly can, but the vast bulk of cases that I see would be associated either with cataract, PRA, or SARDS. If we are doing our diagnostic testing on these cases and the findings are not really consistent with either of those groups of diagnoses, then we do start to think about other conditions, like maybe it's the optic nerve, maybe it's in the central nervous system, maybe there's some other slightly odd retinal disease going on. So regarding cataracts, I think, cataracts are definitely the most important treatable cause of vision loss in dogs. It's something that it depends on the nature of the cataract as to how treatable it is, and it depends on the state of the dog and the state of the eye as to how treatable it is. But it's definitely the most important cause of vision loss that we can actually do something about. As I said earlier, there is a variety of different causes, which will kind of cover the diabetic stuff specifically in an upcoming slide. But diabetes is a really big, important cause of it. I would say of all cataract surgeries that I do, probably a third, maybe more of them would be diabetic dogs. It wouldn't be half, but it wouldn't be far from it. Genetic cataracts, some breeds are higher risk than others for developing these, and they vary in their severity and their rate of progression. And then the senile ones, like I won't spend a lot of time talking about senile cataracts today, but we do the odd senile case, and they're always a tough one to figure out because, if you've got a 13, 14-year-old dog and talking about cataract surgery, you have to be really careful to be as confident as we can that cataract surgery is going to as likely as a good chance to succeed for starters, but also that it's going to have a life-changing improvement in that dog's quality of life. Because it's quite a lot to put the dog through. It's not a small procedure, and there's not a small amount of cost associated with it. But we've done, I don't know how many senile cataract cases now these days. I mean, quite a few anyway, and it's something that it whilst the dog might not live that much longer, it's really nice if we're able to give it vision and give it an ability to interact with its environment, have it the best quality of life possible for the rest of its life. And for cases that are suitable for surgery like that, we're happy to kind of consider them and take them on and discuss it with the owners. but it's not that all dogs with cataracts are suitable for surgery, and certainly not that all geriatric dogs are suitable. But just because they're old, it doesn't mean that they're not either. And we've certainly had some really, really great outcomes with some old dogs and had a big improvement in their quality of life. So diabetic dogs, typically the blindness will occur. I mean, it does very little, but most of them they'll go from being pretty much visual to blind over a week, maybe two. Like they usually will progress very quickly. And that is often associated with a lens-induced uveitis. So we're getting a lot of water going into the lens. The soluble proteins within the lens leach out through the lens capsule and stimulate inflammation inside the eye. So they often can be quite red eyes as well, which is, a concern. Um, my preference for these cases is to operate on them as soon as reasonably possible. And the reason for operating on them as soon as possible is that a lot of these eyes don't last. There's a ticking sort of a ticking time bomb really of how long they like. Some dogs will last for months without surgery and they'll be fine. Some dogs will come to me and they've had cataracts for a couple of weeks, and I'll look at both eyes and say, well, I can't operate. It's got severe uveitis and glaucoma in both eyes. Is that ship has sailed. And so to minimize the number of cases where they kind of become inoperable over time, we try to get them in and operate as soon as reasonably possible. And as part of that, I'm happy to move forward with them without perfect glycemic control. But they need to be like controlled enough. I think there's some good indicators that they are under good enough control to be a safe anesthetic. One is that the weight has stabilized and or is increasing, indicating that the amount of insulin going into the patient is appropriate. Establish that they are responding to insulin, via either glucose curve or continuous monitors. And we also want to make sure that they don't have ketonuria, which would obviously indicate inadequate control, or any urinary tract infection. Obviously, or any other significant systemic health issue. But I don't expect them to have a picture perfect curve that stays within normal levels throughout the whole day. Because let's face it, how many dogs ever achieve that? And so as long as they are fit and healthy enough and their diabetes is well enough under control, then they become a candidate for surgery. And so, briefly, just to give you an idea about what cataract surgery actually is and what's involved is, technique is that I use called phacoemulsification with intraocular lens implantation. We use, it's a small incisional surgery. I use a 2.4 millimeter incision, and we have an ultrasonic energy delivered via a needle and a machine, which you can see sort of in the background of that theater image. And that ultrasonic energy kind of breaks up the lens and makes it, liquefies it so it can be aspirated out of the eye via this small incision. Once all that cataractus lens has been removed, we implant an artificial lens in its place, which corrects them back to basically normal focusing ability. Estimated success rate for surgery, I advise people, is about 85 to 90%. So, I would consider it a high success rate procedure, but we definitely have failures. Like it's not 100% successful. It's really important to highlight that to the owners, that particularly for the senile cases, that they have to be acknowledged that failure is a very realistic potential outcome for them. Even though the bulk of cases go really well, we still unfortunately do have cases which don't. I would say that's pretty fair representation of my success rate, and that would be in line with the conventional kind of success rate internationally, according to literature. After surgery, they wear a cone for a couple of weeks, and they need to avoid knocks and bumps of the head for a month. Eye drops starting at 3 times a day usually, and then oral medications as well for a few weeks. And then that tapers down over several weeks. Do quite a lot of reassessments post-op. And for cases that come to me outside of the area where I'm not doing the post-operative monitoring, we do that in a collaborative manner. So I'd say 2/3 or more, 3/4 of the cases I operate on come from outside of the Waikato. And so the way that we manage those is that, we communicate to the local vets, advise them what they want them to do for the reassessment. The local vets do the reassessment, give me the information, I interpret it, and then I send back an updated treatment plan and new reassessment recommendation. We just kind of do that back and forwards until we get through the post-operative period. And I've been doing it that way since I've been at Hamilton for the last couple of years, and I feel like it's been going pretty well. I think it's been a really good way to be able to offer these surgeries to cases which wouldn't be able to come back to Hamilton for reassessments. That's quite common, particularly in diabetic dogs, that they'll need to stay on a topical anti-inflammatory eye drop once or twice a day. Because just to control or prevent recurrence of uveitis inflammation after surgery. And just, to give you a bit of an idea about what's involved cost-wise, cataract surgery and a bilateral cataract surgery in a typical diabetic dog's ranges sort of 6,500 to 7,200. And that's kind of including everything from my end from the day, surgery, medication, lens implant, ... All right, so that's cataracts and specifically diabetic cataracts. So move away from lenticular causes for vision loss, and we'll move now to retinal causes for vision loss. And this would be probably the most common, most important cause of sudden onset bilateral vision loss in dogs, I would say. Cataracts usually aren't sudden onset, right? There's some time. Diabetics can be the exception to that, but this one here, often they'll be like fine and then a few days later blind. And so there's a syndrome called sudden acquired retinal degeneration syndrome, and they follow a pretty typical signalement. Almost always follow this sort of signalement. They're small to medium-sized dogs, 10 kilos or less, almost always over middle age. It can be older, but almost always, I don't think I've ever seen a young case of SARDS. And often, but not always, associated with Cushing-like symptoms beforehand. I had a Dachshund. Yeah, it was a Dachshund. I forget how old it was, but it was about that middle age. I had a Dachshund recently, which came to me. They'd been at their vets earlier in the year, so a few months ago, 6 months ago maybe, with complaint of significant weight gain, despite what they were doing with it. It would just keep piling the weight on. The vets had done all the appropriate investigation and workup and hadn't found anything abnormal. And then 4 or 6 months later, it goes blind. Oof. And then it comes and sees me, and I say, look, it's most likely to be SARS. And they have these Cushing-like symptoms, but they are not Cushionoid. Right, so you can do your low-dose DEX or whatever screening test you want to do to assess for Cushing's, but they don't have Cushing's. They have the symptoms, but they don't have Cushing's. Often they may have elevated ALP as well, right? They have quite a lot of symptoms. And so it's not something which, and I suppose the other side of that is dogs with Cushing's don't get this. Like I haven't seen a dog that's known to have Cushing's that then also gets SARS. I'm not saying it couldn't happen, but I'm not aware of one that I've seen. And so it's just an interesting link between these symptoms, before vision loss and then vision loss as well. And I don't think that for my case I just described, I really don't think that the vets missed an opportunity to diagnose SARS, because you just don't, that kind of comes out of nowhere. There's no way you could predict that was going to happen with that dog. But when you look back at it in hindsight and go, oh yeah, that makes sense, that makes sense, that makes sense. That's often how these cases go. They usually have a pretty typical reflex profile, so they'll be they're no menace response, so nothing, no blinking to a menacing gesture. They'll often retain some sort of pupillary light reflex though, but they'll typically have really big wide pupils. But when you hit them with a high intensity light, often the pupils will move. And as part of that, they'll often have the dazzle reflex preserved, presumably because the cells which mediate the dazzle reflex actually aren't the primary ones which are damaged during a SARS event, which are the photoreceptors. And in the early phases, the fundus looks normal because it happens so quickly and suddenly. There isn't enough time for the retina to undergo any degeneration change. And so if these guys are caught early, they have a normal looking fundus. And so that's where we kind of rely either on the history and or the reflex profile, or potentially some additional testing to help figure out what's the cause of the blindness. So, obviously fundus exam is a really important part to try and identify what may or may not be causing it. Electroretinogram is something which can be done, which is basically put under a sedated dog, put electrodes on and around the eye, and then use a machine to flash light into the eye. And those electrodes pick up the electrical activity in the retina. And if light goes in the eye and the retina hyperpolarizes and depolarizes, as it should do, then that tells you the retina's functioning. But in a SARD's case, if you're putting light into the eye and measure the electrical activity, it'll end up in pretty much a flat line. So that's really classic for SARDs. And then there's another test called a chromatic pupillary light reflex, which is also quite useful for these, where you're using very specific wavelength light to test your pupillary light reflex, and that can help differentiate the abnormal and the normal functioning parts of the retina. Unfortunately, for this syndrome, there's no effective therapy. There's no known. The big issue we've got is that we don't know what causes it. We don't. It's been around for a long time. It's worldwide. It's not unique to anywhere, but we don't know what causes it. There are some people who will try really adventurous, intensive, risky treatment protocols, which I don't recommend. But yeah, unfortunately, we can't offer any treatment option for these. Good news is that the bulk of these cases, in my experience, but also according to one or two surveys in the literature, adapt really well. They're able to live a good quality of life as a blind animal, and they are, after a month or two or three, kind of able to live a decent quality of life, different life than they did before without vision, but still a good quality of life. And another cause of vision loss in dogs associated with the retina is called progressive retinal atrophy, or PRA. Really, really common, really common. Typically don't present as a sudden onset vision loss, but more of a, gradually progressive vision loss that then reaches a threshold that then cues them to come in for assessment. In almost all cases, they'll have night vision loss initially that then progresses to vision loss during the day. It's a genetic disorder. It's heritable. It's a really important genetic disorder. The specific genetic abnormalities that cause this have been identified in a number of different breeds, but not all breeds, and not all genetic varieties of this condition. But there's a lot of value in genetic testing for these to identify either clears or carriers, which is super valuable, or affected dogs. The other value for genetic testing for these is that they usually don't present until they are, 6 or older. I mean, yes, there is the odd ones which may present at a younger age, but they're usually presenting as older animals. And so even if they are having regular eye assessments, they might not have any lesions, which would let you think that it would be affected until they're a little older. So genetic testing is a super valuable thing, particularly in a Labrador Retriever, before considering having these cases as part of a breeding program. And yeah, it's a variety of breeds, but wow, Labrador Retriever would be, 80% of the dogs that I see with this. It's super common in that breed. Again, they have a relatively typical reflex profile. They've got a variable menace. It depends how degenerate the retina is. And they'll often have some PLR and some dazzle reflex, but again, it depends on how degenerate the retina is. If it's early stage, then they might be pretty responsive. If it's right at the end stage, maybe there'll be nothing. And the tracking response is super useful in these cases because we can help differentiate visual performance in bright light and in dark light. And so they may track, again, depending on how bad the retinal degeneration, they may track a moving target in bright light. But you turn the lights out and they don't track it, then that's really strongly suggestive you've got a condition which is specifically affecting or selectively affecting the rods or the photoreceptors, which are most important for vision in dim lighting. And that's how almost all of these PRAs are initially rod photoreceptor disorders. They commonly will have cataract secondary to that. And almost all of these cases are not suitable for cataract surgery because if they've got really advanced retinal degeneration and then they get a cataract and then we fix the cataract, they've still got really advanced retinal degeneration. There are a couple really important exceptions to that in breeds, and that would be, in my opinion, the Cocker Spaniel and the Blue Heeler or any sort of Australian Heeler, because those dogs often will get cataracts early in disease. The retinal disease doesn't progress as quickly, and they can be really quite um, viable cataract surgery candidates. But most of these cases, I think, are poor cataract surgery candidates because do surgery on the lens, doesn't fit the retina, it's still blind because of the retina. Kind of not a good situation to be in doing cataract surgery. And fundus exam on these cases, I'll have marked pedal hyperreflectivity and vascular attenuation, which really is the bottom image we saw in one of those early slides where you basically have no vessels you could see. The retina is like super reflective, like almost blindingly reflective. And the optic nerve is often pale or shrunken. So, just to let you know sort of who we are and what we do and stuff, I mean, if you've got cases that you would like assessed with vision loss, there's a couple different options. One is that we assess them. I'm based in Hamilton, and we're here. Well, we're here except for when I'm on holiday and I'm not. But we also offer a remote consultation service. We've been offering that for the last few years or more. And I'd say with the cataract cases, probably 80% of them come via that pathway where they're assessed locally. All the initial consultation process is done before the owners leave the region. And the bulk of the communication's done as well before that, so that we're able to kind of get them into us pretty efficiently with a minimum amount of time. They don't have to stay here for like a week or more. Keep the cases moving through efficiently for my practice, but also from the owner's point of view. And it also sets us up for managing the post-op in a collaborative manner where, we kind of very much use the local vets to do the assessment and the testing, but I do the interpretation and the planning. And I think that it's quite a nice approach for managing these complicated cases. And look, I kind of was quite keen to do this talk and sort of bring up the topic of cataracts and cataract surgery, vision loss as well, but specifically cataracts because it's something that we really like to do here. It's something we're motivated to do. It's procedure I've been offering for, I don't know, last 12 years or something. And we find that it's whilst it's a really difficult surgery to do, it's expensive. It requires a lot of time and effort from the owner's point of view. We find that the reason that we like to offer it is that it offers really high, massive, positive impact on the quality of life of patients. The whole reason we do it is not to restore vision. That's actually not the point. The point of doing cataract surgery is to optimize quality of life, is to really just give them the best quality of life possible. And if they're a case which is likely to benefit significantly from that, then they may be a case for cataract surgery. And we find that that the client satisfaction with it is really high. They perceive a lot of they appreciate seeing their dog being able to see again. And again, as I said, not all cases are suitable for surgery, and not even all cases will succeed. We do have some failures, and that's it's just how the nature of the condition, but nature of the surgery. But it is something that we like to sort of promote, I suppose, because it's kind of nice opportunity to have a really a positive impact on patients' lives and also the owner's sort of ability to live with them and all that sort of stuff. So thanks for listening, everybody. See, most of you made it to the end, which is great. And if you have any questions, please type them into the chat section up the top. I see I've got a couple to go through, which I'll just start going through now. But if you've got any specific questions, then please write them in the chat and I'll start working my way through them. So first question we've got is that do we need mydriasis for retroillumination to check for lenticular nuclear sclerosis or cataract? Short answer to that is no. You don't need mydriasis to do that. You would want to have mydriasis, I think, if you were looking for lesions affecting opacity peripherally, right? So if you were looking to say, oh, we want to check for cataract right on the periphery, then yeah, you would want to have that pupil as wide as possible so you could see as much of the peripheral lens as possible. However, what we're really interested in is what's the clarity in the visual axis, and that's going to be the central part, right? You're going to be doing this test in a dark room. You're also going to be doing this test with the light and with the light intensity not really high, which means that the pupil shouldn't close down a ton when you do it. And so you'll get able to just rely on the natural sort of state of the pupil being relatively dilated to be able to assess the visual axis clarity through, I don't know, 60 to 80% of the lens, I would say, something like that. So no, I don't think you need mydriasis for retroillumination specifically. Now, if you're wanting to develop a fundus exam technique, try and learn to look at retinas and things like that, I think having a mydriatic help you with that is really useful. It makes it a lot easier. A lot easier to try and look through a pupil, which is this big, compared to peeking through a keyhole, which is tiny. And so something like tropicamide, which is really, good mydriatic is, I would recommend that you would use for that. But specifically answer your question, no, not for retroillumination. So great question. There's another question. So what have we got? If cataract surgery, sorry, is not an option for a diabetic patient, is topical anti-inflammatory helpful for long-term use? Well, I would say it is helpful for long-term use if there's inflammation. And if there's not inflammation, then there's not any point having it on anti-inflammatory therapy. You may have it on topical anti-inflammatory like a topical steroid, or you may have it on topical anti-inflammatory like a topical non-steroidal anti-inflammatory. The topical steroids, the most obvious kind of disadvantages with that approach would be, well, one, the steroids may, not definitely, but may interfere with glycemic control and induce some degree of insulin resistance. And I find that dogs are hugely variable in their sensitivity to topical steroids for that. And secondly is three. Secondly would be if the dog was to get a corneal ulcer, then it would be at risk of getting melting corneal ulcer if it's on topical steroids. So that's the case for any case, whether they're a diabetic or not. And probably more at risk for diabetics than non-diabetics is that they've got metabolic abnormalities. If you're putting steroids onto the eye, then potentially it could increase the amount of lipid deposition in the cornea. So you could get a corneal lipid dystrophy, lipid degeneration. Usually that's pretty minor, not important, but that's another thing. You can use topical non-steroidal anti-inflammatories as an alternative, and the benefit of that is that they're not going to have any impact on glycemic control or insulin response. The disadvantages of it are that it's less potent than topical steroids, which may or may not be important. If the topical non-steroidal, like Acular is probably the most commonly encountered one, but there's diclofenac's another one we use now as well, depending on what's available. It's less potent, but it might be potent enough. If they were to get a corneal ulcer, they are still definitely at risk of perpetuating a melting ulcer, same as steroids. All right, so non-steroidal anti-inflammatories topically, I don't think are any safer than topical steroids in the presence of an ulcer. And thirdly, ketorolac specifically, which is Acular, is a non-specific COX inhibitor. And recently there's been a couple articles showing they basically put it in dogs' eyes and then they do a gastroscopy. So look at the gastrointestinal mucosa. I think that maybe they do some fecal blood testing or something as well. Anyway, they found that a huge number of those dogs had gastric ulceration. Now, it would be fair to say that would either be potentially insignificant or subclinical based on previous experience, right? We've had a lot of dogs in the past on Acular and they seem to have been fine. Except I've had 2 dogs nearly die on me with bleeding gastric ulceration that have been on Acular. And so I'm really gun shy of it. And I would say, I don't know how many dogs I would have treated with Acular over the years. It'd be a couple or more 100, I would say. And I've only had 2 which have got severe gastric ulceration and nearly died. But I'd just rather not go there. So I'm real gun shy of Acular. And the topical anti-inflammatory is not going to help the cataract at all, right? It's just hopefully maybe help the eye stay comfortable if it's suffering uveitis. So, it's a very long-winded way of saying, is it helpful for long-term use? If it's inflamed, then yeah, I think it's important. If it's not inflamed and not necessary, then I'd probably not use it because it's not a risk-free treatment. So that was a longer-winded answer than I had intended. Um, so then another question, why do we need to continue topical anti-inflammatory drops after cataract surgery? Is it not just used pre-op to help with uveitis inflammation? Yeah, so in veterinary species, well, dogs really would be the bulk of them, the blood aqueous barrier is way more unstable than it is in humans. And so in humans undergoing cataract surgery, they typically will suffer very little intraocular inflammation, and the blood aqueous barrier stabilizes really quite well. And so almost all of those cases, to my limited knowledge, then don't need ongoing treatment. But however, that doesn't seem to be the case in dogs. Dogs get way more inflammation post-op after cataract surgery than humans do. And also, they definitely are at risk. No, that's not quite right. A lot of them will get recurrence of uveitis after cataract surgery, even if they've been on a tapering medication plan for a few months. And so practically, when we're monitoring these cases post-op, that's what we're looking for, is seeing is the issues being controlled successfully or not. And also, once we're getting down near the end of it, we might try them off treatment, see if they're stable off treatment. If they're stable off treatment, no recurrence of inflammation, then great, they stay off. But I would just set the expectation, particularly with diabetic dogs who've got funky immune systems, the eyes are all often inflamed before surgery, so they're already pre-wired to be inflamed. I'd set the expectation that they'll probably be on long-term anti-inflammatories after surgery as well. So it's a good question. Another question. Another question. That's a question. No, no more questions. So if there's any further questions, here's your last chance call. And I'm happy to answer them, but I would say that at this stage, look at that, just over an hour. Happy with that. Um, so uh, if you have any further questions, let me know about this. But otherwise, I think we'll say that that's enough for this talk today. I hope that you got something from it. And there are some other resources which we kind of have, which can sort of help improve your understanding of vision loss and ocular exam and reflex testing, that sort of stuff. But it looks like we've got no more questions, so I'm going to stop talking. Again, thank you very much, everyone who came out to this, and hopefully you took something away from it. So we'll sign off now. Thanks a lot, guys. If I can figure out how to stop it. Where are we?